is Roy van Wanrooij. I'm a gastroenterologist specialized in hepatobiliary interventions at the Amsterdam UMC.
And my name is Jeska Fritzsche. I'm a PhD candidate at the gastroenterology department in Amsterdam UMC. And also on behalf of the co-authors, we would like to thank Endoscopy for the opportunity to discuss the results of the Scorpion pilot study. A prospective study in which patients with a distal malignant biliary obstruction underwent EUS-guided choledochoduodenostomy, EUS-CDS, as primary drainage strategy instead of ERCP.
For patients with a distal malignant biliary obstruction, standard treatment is considered ERCP with placement of a LAMS, a self-expandable metal stent. EUS-guided choledochoduodenostomy is a relatively new technique that allows the endoscopist to create a biliodigestive anastomosis distance from the tumor and also the pancreas, thereby precluding the risk of post-intervention pancreatitis. Based on current data, EUS-guided choledochoduodenostomy is already be considered the first alternative after failed ERCP. However, current studies use standard SAMs to create the anastomosis, while the use of a lumen-apposing metal stent, the LAMS, simplifies the procedure. Until recently, there was a lack of prospective data on EUS-guided choledochoduodenostomy using LAMS as the primary drainage method. Therefore, aim of the study was to assess the safety and feasibility of this technique using LAMS as the primary drainage strategy in a prospective study.
30 patients with a distal malignant biliary obstruction without clinically relevant gastric outlet obstruction signed informed consent. However, 3 patients were ineligible because on-site cytology was not representative of malignancy. In 2 patients, the CBD was less than 12 millimeters, and in 3 patients, there was no safe window to place the stent due to ascites or because the tumor was too close to the hilum. In 20 of the 22 enrolled patients, the procedure was technically successful, and only 1 patient experienced a procedural adverse event, naming a perforation due to mal-deployment of the stent, which was endoscopically treated during the same procedure. Clinical success was achieved in 19 patients. However, more than half of the patients developed stent dysfunction within 6 months after technical successful stent placement. This was most frequently caused by food impaction, with or without concomitant gastric outlet obstruction, or alternatively by obstruction of the LAMS by the contralateral bile duct wall. In 1 patient, obstruction was caused by sludge, and in 1 patient, cause of obstruction remained unknown. Conclusion: this study confirms the safety and feasibility of the procedure. There was, however, a high risk of stent dysfunction, and not every patient seems eligible.
So while results of EUS-CDS are promising, this pilot study shows that EUS-CDS with LAMS solely is not yet ready to replace ERCP as the primary drainage strategy in patients with a distal malignant biliary obstruction. Further studies should focus on the benefit of coaxial stent placement or alternative stent designs. We would like to thank you for your attention and are looking forward for the next steps.